All right. Good morning, everybody. Here's talk number 2. Thanks for being here on day 3. The topic for my talk is going to be on mainly platelet-rich plasma. We're going to just reference other orthobiologics, and I'll kind of tell you what I think right at the start. But mainly at UCSF, we're doing PRP, and that's probably one of the more common things you're going to see in the orthobiologics. So just to give my disclosures, I do some digital health work. It shouldn't affect this talk here. And for UCSF, we have 2 systems for PRP. We have the Regen unit, that's I believe from Stryker, and then the MSite unit. So I'm actually going to demonstrate videos of how that gets done, so you guys have seen the process of PRP production. And yeah, we can definitely answer questions. So for this talk, because it's kind of more of a workshop, smaller group, please feel free to raise your hand and we can take some questions live during the talk, just because there's a lot of information. And if you have a good question, it might be timely to just answer it right on the spot. So I'd like you to just think about your own practice and, did you have a patient that had a PRP and what did they get it for? And maybe who did it for them? I'm always shocked to see how many people have done PRP even on themselves. How many people have had PRP in the room? Really? Wow, okay, so I would have guessed even more. Sometimes these patients come in, I'm telling them about PRP and they're like, oh yeah, I got that 5 years ago or even 10 years ago. It's unbelievable how common PRP may be in different practices. So what I'm going to really kind of try to highlight for you is what is PRP, why does it work, what is kind of the evidence that's out there, and then what we do here at UCSF. But again, I welcome any questions that you have in your own practice, question that people have asked you, because I think it'd be great to share kind of what you're experiencing, because I'm sure we all see it. So just to talk a little bit about platelets, I found it fascinating I'm doing some research, so I'm looking more into the biology. There's 250 million platelets in every cc of blood. So you think about how much that microscopic stuff. And inside of that is all those growth factors and things like that, as you see in the center of the diagram. But they have many biologic effects on different organ systems throughout the body. It's not just the simple, hey, platelets stop bleeding and that's it. There's so much more that platelets do in the homeostasis of the body. And science has been looking at platelets since the 1800s. And the interesting thing is those growth factors have so much effects on the immune system. So it's not just clotting. My dad's actually a hematologist, so it's really fun talking to him, because if you talk to a hematologist about this stuff, they know all about platelets. They'll tell you all kinds of stuff. But in orthopedics and sports medicine, this is kind of a new thing. We don't really think about this on a day-to-day level. So talking a little bit about the history of PRP, I think you can kind of maybe date it back to around 70 years or so. In the 1940s, that's when they started to understand about these growth factors in the cytokines, and that was really important for healing. But it wasn't until around the 80s that we really started to apply it for wound healing and things like that. So, in 86, they'd started using these healing factors. But interestingly, I don't know if people have been in the Bay Area for a long time. I have a colleague named Dr. Cannon. Anyone remember that name? So Dr. Cannon has been a surgeon that's really kind of pioneering on ACL. He's kind of low key, so he never really kind of pushed himself, but he probably retired maybe 12 years ago or so. But he actually would spin clots and put in all his meniscus repairs and things like that, because he just knew that the clot was really valuable. So this whole healing concept is not new. In the 90s, a lot of the oral facial surgeons were healing mandible fractures using PRP. So a lot of this came out from dentistry and oral surgery. And then we started to kind of use it in orthopedics probably in the early 2000s. There are a lot of researchers even in the Bay Area down at Stanford. They are doing a lot of the early tendon work. So as you see some of these names, you might have interacted with them here in the Bay Area. But like, if you just Google PRP, it's fascinating. Like, we're just a little fragment of who's using PRP. Like, most of it's being done in cosmetics, hair loss, vampire kind of treatments. Like, it's crazy. That's why like PRP is in people's minds. Like, we don't think about it as much, but they are. And, there's a lot of history in using it for athletes. I think maybe Kobe Bryant was the biggest name. That was in 2011. I think the NBA was on a break. They were on some kind of strike, and he went out to Germany and got this done. If you search this, you'll run into this funny article. Like, it says that Kobe went to the same person that the Pope went to and stuff like that. So PRP is important for big people. So let's talk about what platelet-rich plasma really is. I think the definition now is to just describe it as any concentration of platelets above your own autologous blood. They kind of made it vague. Like, I would say maybe 5 years ago, it had to be 3 times more. Now it's just more. And we're going to show you how this works. But a lot of times you have to prepare the blood to separate off the plasma, get rid of the white blood cells, and concentrate those platelets. So sometimes there's 1 to 2 spins involved with the different machine that you're using. And we'll talk a little bit about what do you do with these white blood cells. There's many different machines out there. So I think as this has become more popular, every orthopedic companies have been coming out. There's even a couple outside, so you should definitely check out the vendors. And thanks to Dr. Feely for the slide. He just walked in the front here. But I think that's why it's a little bit hard to always compare, because you're preparing the blood a little bit different. I don't think you can always say what you're getting is the same. So again, this slide shows that in the growth factors with the different systems, you're seeing very variable levels of the growth factors for each one. So and what we don't fully understand is which growth factor is doing what exactly. We know a lot of these are very important for healing, but what is it actually doing for our patients? The other complicating thing is that the PRP level can change in yourself every day, your platelet concentrations. This is just a graph showing just several individuals at different ages, and you can see those bars with the different colors. They're just like different times of the day where they drew the blood, and there's different counts. So when you look at the studies in the literature, it's really hard to compare all this stuff because there's all these different variables that aren't being controlled for. I would say maybe around 5 to 7 years ago, I think the biggest thing that we were all talking about is like, how much white blood cells do you have? And you might have heard of leukocyte-rich and leukocyte-poor. And at the time, maybe people were thinking like leukocytes, white blood cells, they have a lot of enzymes in them, like they kill bacteria. So they're very inflammatory, not really that great. But sometimes we were thinking soft tissues like tendons, maybe that would be better. We'd leave some white blood cells in there. It would actually hurt the patient a little bit more, but maybe we want that inflammation to get the tendon to heal. Whereas arthritis, people were feeling, well, we don't want a lot of inflammation in the joint. We just want the growth factors. I think we've kind of settled that really we want more leukocyte-poor plasma for most indications. That's kind of been the trend. They kind of shown that like the tendons didn't do much better with leukocyte-rich versus leukocyte-poor. So I would say that's not that huge of a debate nowadays, but that's what people were talking about a while ago. So looks like getting rid of those leukocytes is better. The other questions is like, should they be activated? So in the platelets, you have these vesicles. So it's not the platelets that we want. We want the vesicles and the growth factors inside of them. And I'll say that as a caveat. We don't really know. Maybe there's something else in these platelets that are more valuable too. But I think where we are right now is that we want to get as many of these growth factors. So when it's in your body, like I always give the analogy, okay, you cut your hand, your platelets go in, they stop the bleeding, then they release their growth factors, and now your body triggers all those immune cells to come and respond and heal the area. So, you do need to think about, do we need to activate these growth factors to get them out of the platelets? So there's a lot of discussion about that. Some of the old systems used to add chemicals to actually activate them and release all the growth factors before you injected them in. But a lot of times just with the injection and some of these mechanical processes when you're just injecting, a lot of these growth factors will come out already. So let's show you a couple of these systems live. And again, feel free to ask questions. This is the Regen system. This is a lot simpler. It comes in a nice kit, so it's like really easy to use. Everything's right in the box. And for this one, we're only taking 8 to 9 cc's of blood. So it's not a huge amount of blood. So, we said it's 250 million platelets in a cc, so maybe we're getting, let's see here, 8 times 250 million, so a couple billion. So I'm just preparing the stuff. To me, the blood draw is still the hardest things, like for the phlebotomists out there or people who are really good, that's always awesome. Knee injections, I have no problem. Drawing blood can be hard in the older people. I think if you do this, definitely tell your patients to drink a lot, have breakfast, all that kind of stuff makes a difference. I'll always ask them, hey, which arm do they give blood in? Because they usually know which vein they like to go for. Just makes life a lot easier. See, I'm very slow at blood draw. I'm using a 21 gauge butterfly on this one. The butterflies are just easier to draw blood. Some people worry about like the needle being too small. A lot of people will talk about 20 gauge and higher is preferable because you might destroy a lot of the platelets as you're injecting, right? Maybe that'll be good for activation, but you might also destroy some of the platelets and wreck things up. So until we kind of know how this all works. The nice thing about this system, especially for older patients, super easy. It's just a simple blood draw. Although you'll be surprised if you have very friable veins, just the vacutainer can blow veins up. So just little things like that. So pretty simple that we get that. Then we're just putting the tube. It's a normal centrifuge. We do it right in the office. Very important to counterbalance. So there's another like tube that we do, and you got to make sure they're perfectly level. This company's changed their tubes to more plasticky type tubes because the glass ones were breaking if you weren't perfect on the balancing. So anyways, it just spins for 9 minutes on the system. And basically, now you kind of see that it's separated. You see the plasma layer. So the neat thing about this system is they have a proprietary gel. If you looked at the bottom of the tube, you'll see that there's this kind of whitish layer that's kind of now mixed in with blood. But it pushes all the red and white blood cells through that gel layer, and now all we want is the top. And now the platelets get kind of smushed down along the side of the tube and on the gel. So you have to resuspend this. And you'll see this in the other system that we're going to show you next. It gets a little pinkish, like blood tinged a little bit. It's probably not perfect to get rid of all those red blood cells. But again, it's another little kind of syringe Vacutane thing. You just take the plasma out of your Vacutainer. And it's a little dark. It's not looking that red on the system. And usually I get around 5 cc's of volume for the PRP with this one. And then it's basically just a straight up knee injection. Now, for a lot of the tendon procedures and other joints like the shoulder, hip, all that kind of stuff, I'm not doing blind injections. Personally, I kind of find the knee is easy to inject. So hopefully you guys learned how to do it downstairs at the knee injections yesterday. But I kind of find it's pretty straightforward. So it's kind of harder for me to actually hold the ultrasound probe and really get under. I just get underneath the kneecap, and then you won't feel resistance. You just get it right in there. And that's kind of all it is. Unfortunately, as I'll kind of tell you guys, you can't give anesthetics or anything like that. Like if there's an effusion in there, I'm going to draw out as much effusion as I can just to get rid of anything that's bad in there and all that inflammatory stuff. Makes them feel a little bit better. That's just synovial fluid that you're seeing there. And then you can just dial that off and then inject the PRP. How many people do PRP in the audience, in the practice? Cool. What system do you guys use? Arthrex? Arthrex. Pretty happy? Easy? Yeah. We used to do the Arthrex, the double syringe one. Is that the one you're still using? Yeah. And I think some of the, as you're going to see in the M site, having the anticoagulant was nice. The double syringe, if I ever messed up on the blood draw, it would clot and stuff like that. Yeah, you're nodding. That was always a tough one. So then I'm just injecting the PRP. Cool. So next we're going to go into the M site. This is kind of something that's been more popular. Like Dr. Berrigan was here, but he didn't give any talks because he's on paternity leave. But he trained at Emory, and I would say this is one of the more popular systems that's out there. So Scott, maybe I'll play that and go to the minute number 1. I think the advantage of this system is that you're using a lot more blood. So this is just drawing sodium citrate. So you use an anticoagulant in all your tubing. So that makes the ability to do a more prolonged blood draw easier. You're taking a huge amount of blood. So I put 6 cc's of sodium citrate and then take 54 cc's of blood. And basically you just push it into this first container. So this is going to be a double spin technique. So you're putting all the blood, it's mixed with the sodium citrate. You got to counterbalance it. And then usually the company will give you or sell you or rent you the centrifuge. So the cost of that is not really that much. It's really the kits that cost the money. And then you spin that for a couple of minutes at 4,400 RPM. Cool. So that's what you get afterwards. You see how it separates, but there's no special gel in this one. So the plasma's at the top. There's actually a buffy coat layer right above the red blood cells. So that's where a lot of your white blood cells are. So you actually just take this syringe and then it kind of sucks out all the yellow stuff. You don't want any of the red stuff. So once you see red stuff going in the tube, you stop. And now you put it in the second container. So this is the second spin. At this spin, you're going to be taking the plasma and the platelets, and you're going to be concentrating the platelets even more. Cool. So usually you get around 30 cc's from 50, like a 54 cc blood draw. And then there's a special cap that's more, this is an instructional video for people. If you don't put that cap when you spin it, all the PRP goes all over the place. So you got to make sure it's counterbalanced really good. The next spin is going to be for 4 minutes. So it's a little longer. Overall, I'd say this procedure takes me around 40 to 45 minutes. That includes the injection for the patient. And while it's spinning and stuff like that, I'm telling them about the aftercare, which we're going to get into. So if you take a look now after the spin, you see that reddish stuff over? That's the platelets. It usually forms a disc at the bottom of your container. And then so now you draw off as much fluid as you want. So you can actually control how much plasma volume you have to inject. So if you wanted to make a kit a little less concentrated and have 10 cc's, you can do it. The company usually recommends you're at around 7 cc's. And so you kind of leave it there. Now you got to resuspend it, just like the other system. You got to like swirl it around. It takes like a good minute or so to get all those platelets off. So you just whisk them all off, and you can kind of see it's turning pink again. And then you're into a normal injection again. Any questions or anything like that? I just thought it's interesting if no one's ever seen some of these systems. Question?
Do you worry about infection?
No, well, they're all sterile procedures, right? It's just like a blood draw, and you put it in vacutainers. Like, you're never really touching the blood and the plasma. All of these things come in sealed. They're like almost like OR packs, and you got to open them. I'm actually not using sterile gloves. So as long as you're not touching the actual needle kind of points, you're not going to get any introduction of infection in the system. Like, you think about, we do this in the office. It's not really a sterile procedure for the most part. I think there was another hand somewhere. No? All right. So let's talk a little bit then about how we measure PRP and stuff like that, because we talked about how it's hard to really compare the study. I would say we're still very early in the science of us understanding this stuff. Right now, I think the controversy is not about white blood cells, yes or no. I think really we're now talking about platelet count and how much platelet count we want. And I think most people are feeling that more is better. We can also measure a lot of these growth factors. Like, there's a lot of the studies that kind of publish stuff are looking to see what's inside these platelets. And so Dr. Berrigan actually addressed this in a meta-analysis study, or systematic review, that he did. He did this with Zach Bailowitz. If you guys were in the ultrasound sessions, he was here yesterday, and Dr. Lansdowne. And so they basically just reviewed the literature, and they found that papers that were reporting more positive outcomes, the doses if they had platelet counts were higher. So 5.5 billions if they were reporting positive results, versus people that were reporting negative results were around 2.3 billion. So again, we just talked about how all these different papers are using different systems. Each person's platelet levels might change every day, but this is, again, a good systematic review looking at what's in the literature. So you'd have to interpret that the way you think. I would say it's going to be fair. Like, it does look like higher platelet numbers are more often reported with good results. That's kind of what the take-home point. If you want to kind of see how much, at 6 months, like WOMAC is the Western Ontario McMaster arthritis scales. IKDC is another international knee scale. You kind of see that as you go to the right, that's higher platelet numbers. As you map out all the studies, you know, there's a fitted line that shows that more seems to be better. If you look at 12 months, maybe it's a little flatter, but it's still in a positive trend. So, you know, from what it looks like, more platelets is better. But we still don't know what is inside this stuff that's really making it work. And, you know, we'll leave it at that. All right. So AMSSM came out with a nice review in 2021, just kind of summarizing a lot of the data to help the physicians guide their use of PRP for different problems. You see that they're not huge amounts of studies. So this is in 2021, though. So I think over 3 years, this is a hot topic. Everyone's publishing a lot of stuff. But at the time, like tennis elbow, which was kind of one of the most popular PRP treatments, there was only 5 studies at the time. So it's not a ton of evidence that we've got on a lot of different indications. In terms of another review that Dr. Berrigan did, he did it with Joel in the back there. He basically kind of summarized what's out there, and it's a lot less when you look at tendon stuff. And then what he was looking at is like, what was the dosage? Was it even reported? It does show that, like, if you look at the bottom couple, like that's like the number, like it's in billions, right? It's 10 to the 6. So that the bottom two is 7 billion and 16 billion. So those were ones that did show some efficacy. The plus means that it actually worked. Whereas like the other ones that are lower, they weren't showing as much positive results. So again, a lot of variables here. It's just reporting what's in the literature so far. You'd have to take it into account. And if you're doing it already, we are working on limited data. So just going deeper into tennis elbow, because again, that's probably one of the ones that people think about when doing PRP injections. They do better, but when they looked at this review in Cochrane, it was only like a 2% pain improvement. So you can see how when you're lumping a lot of data, you're going to start mixing it. Now, what's the quality of these papers? As we kind of established, not great. So you're going to run into a lot of confusion when you look at the literature, because for every paper that says it's positive, you're going to find one that shows no difference. So really, until we kind of standardize how we do these studies, I think the trend is that we got to measure more things, measure that platelet count, maybe start measuring some of the growth factors that are important. But the thing is, we still need to do a lot of basic science, understanding what's important and how that works. So not great, huge numbers, and that's why it gets a little confusing when you look at the literature. Rotator cuff tears, that's always been a bit of a confusing area too. Like, unfortunately, a lot of the rotator cuff tear studies only demonstrated really benefits when you did it with surgery. All on its own, like just doing a full thickness tear or a partial tear, that wasn't so successful. So you'll see that the literature on PRP in shoulders isn't as good. Now, let's talk about knee arthritis, because again, that's probably, in at least my practice, the number one thing that I'm doing PRP for. You can see that there's a few more studies, at least in that paper in 2021. And now there's like probably well over 100, or well, let me see. I did a randomized a systematic review a year and a half ago now, and there's like 60 or so randomized controlled trials on knee arthritis at the time. What it basically shows, they often compare it against hyaluronic acid or steroids, and so it outperformed both steroids and hyaluronic acid. Hyaluronic acid and PRP were close, with PRP being a little bit better. So the way I kind of use these studies and how I describe it to patients is steroids, if you look at almost all indications, they're usually good for around 6 to 12 weeks. Some people, your patients probably experience better improvement or last longer. It kind of, in my mind, reduces the inflammation, gets them reset, and then you'll see if they get inflamed. If their underlying condition is bad, then maybe it'll get bad again. Hyaluronic acid, as you look at those papers, it's usually typically 6 to 8 months is the duration of relief. And then PRP can be up to a year when you look at their meta-analyses. So that's kind of it. And in these papers, they are saying that hyaluronic acid and PRP were good, getting like good results up to a year, but the PRP was better than hyaluronic acid. The other good news is like there's very minimal side effects with PRP. Like, knock on wood, I haven't run into. Did you run into some?
No, is this just a single PRP injection?
Yeah, that's a good question. So, on the topic of a series of PRP injections, there's definitely evidence that multiple PRP injections are beneficial. It's not linear though, like you get double the effect or triple the effect if you do 3, but it's statistically significant. And when you look at the timing between the injections, like up to 6 weeks is the ones like that's kind of the length of time that you could extend to that you still get positive results. Like maybe 3 months would work. I don't think people have really done that as a study, kind of like big gaps in between. But you'll see that in the community. A lot of people will just go, you want to do PRP, you're getting 3 right off the bat. So for me, I kind of do 1 injection just to see how it works, and it's out-of-pocket costs. So I want to make sure that it actually works for people. But a lot of the patients will just say like, look, I did this before, or I read that 3 is the best. If they want to pay for it, I can do it for them. It's not a problem. So that's just how I deal with that. Now, what about articular cartilage before they get to arthritis? The articular cartilage still may have some ability to repair, so those growth factors are felt to be very important for that. That's where you start thinking about mesenchymal stem cells and stuff. Like, can we get to this before it becomes arthritis? So a lot of people are looking into that. This is just a graphic just to reiterate that you start putting PRP or mesenchymal stem cells and things like that that have really good growth factors. You're maybe not counting on those products to do it, but the effects of those growth factors. Maybe it'll reduce the inflammation. That's what the main pain benefits seem to be with PRP. But then over time, are you going to get more healing and repair? So that's where, like, I think terminology is really interesting. Like, we like to market all these orthobiologics as regenerative medicine, right? But is it really growing new stuff, or is it just repairing stuff? And I would think the evidence seems that it's more reparative as opposed to regenerative. But everybody wants the regenerative, right? That sounds better, right? So I think the summary of wear and tear changes with PRP, I think there's enough evidence that it's helpful. If you guys have had patients, like, you kind of, I would say clinically and anecdotally, yes, it's clearly beneficial for people. But if you really looked at how much they get better, it's not like it's huge. It's not, you can't compare it to a knee replacement. I think that's the problem with hyaluronic acid. It just got bashed because it was really compared against joint replacement surgery. So you're talking apples and oranges here. But we've shown, actually, my colleague Alan Zhang did a pilot study just looking at MRIs after PRP, and we have some MRI techniques to look at the cartilage health. And he showed that, like, actually the signals were looking a bit better over time with PRP, but we still have a lot to understand about what exactly is happening. Like, is there repair and how does it work? You never grow back cartilage, though. So let's look at other areas. What about hamstring injuries? Hamstring tears, unfortunately, weren't shown to have that much. In 6 studies that they pulled everyone together, didn't show that much benefit. But that can be an issue when you pool studies together, right? When we talked about it, if the quality is all over the place, you're mixing it up. But when you do these systematic reviews, hopefully you're getting a better idea of the truth. But again, when the studies aren't great going in, it's not always so good. Now, what about who you send these things to? Should there be guidance? Like, as you kind of heard, we're probably pretty big on ultrasound nowadays and guided injections. So, like, if you're doing a joint, definitely a lot of people can do it under fluoroscopy and stuff like that. And some of our radiologists use CT guidance. I think just being accurate, people are spending money here. You might as well at least get the stuff where it's supposed to be. So I do think that, especially for a lot of these tendons, having a guided procedure is good, because they might also do tenotomies and other types of procedures with this. There's a lot of talk about them even mixing PRP with other things like hyaluronic acid. So a lot of that stuff. The costs are still out of pocket. The only groups that I've seen pay for this is workman's comp, actually. Workman's comp is starting to cover PRP. So that's nice. They're not even arguing about it too much. They're actually just, we haven't had much difficulty getting it for firefighters or police officers and things like that. But, I think a lot of people are doing this in the community. There's all kinds of practitioners. It's not that much to get in a machine. And it's not that regulated. We know that blood products are kind of able to be practiced. And so a lot of these things aren't going to be reviewed too much. So we do have our orthobiologics program at UCSF. Bill Berrigan, Academia, who you've seen speak, and myself are doing it, but Dr. Ramirez is probably going to be starting it up as well. But we're just one group. Definitely every big sports clinic and orthopedic surgeons, they're all doing this now. And there's other providers as well. There's a lot of very experienced people in the Bay Area, a lot of people in the North Bay that have been doing this for even decades. Oh, sorry. So let's get into some of the more practical things around PRP injections. Unfortunately, we can't use anesthetics. If it's going to be an Achilles or something like that, you could do a block proximally to just numb the area down, but you shouldn't really put anesthetics with the PRP. We feel that, it might reduce the effectiveness. So that procedure is going to hurt. So you might as well just warn your patients right there. Now, post-injection protocols is a tricky thing. So this is something that I worked with a group of researchers from Columbia. So Zach Berlowitz was in this as well. And we wanted to just see what's written out there on post-injection protocols. And that might fit better in your world if you're working in PT. It was all over the place. Most people didn't even report whether they're sending in a PT or had some kind of limitations or exercises. The most common thing we found was whether they were reporting they gave them NSAIDs or not. But that was really poorly, 55% said anything about NSAIDs. So it's not just the PRP procedure. There's a lot of healing that's happening after. And so 34% had weight-bearing restrictions. So what do people do after this stuff? And, all we could say from this paper is we don't know. There's no standard for this, and there probably needs to be. So what I kind of do is around the NSAID thing, NSAIDs have been shown, of course, to affect platelets, right? It makes you bleed a little bit easier. A lot of normal NSAIDs like ibuprofen and such, they'll be out of your system within a week. So most people are saying 1 week, no NSAIDs. You can still take Tylenol, that's safe. And then what about after? Afterwards, I would still say a lot of people still restrict. And even on those papers, 55% were doing some kind of restrictions before and after. But those platelets are in your body already. Those growth factors should be working. So, it's kind of questionable about how many days you got to do it for. There's some patients that really do need NSAIDs for other reasons. So, I do think that, 2 to 3 days after, this is again anecdotal, so there's not evidence-based. I would say I kind of let people resume if they need to in 2 to 3 days. But if they can stay off and just use Tylenol for a week, I go a week. And they do fine. This is not that painful of a procedure. So in terms of what I do for the post-injection, I do want to rest because we're thinking about repair. So since we don't have a lot of good standards, I often just apply post-operative principles. What do you do after an ACL reconstruction? What do you do after a hamstring repair? Now, again, this is probably an extreme example if I'm comparing PRP injection to after surgery. But for patients, they kind of get it. They go, oh, yeah, okay, I want to heal. I just spent whatever money on this thing. They kind of understand they got to heal. So it always worries me when people are just I'm going to start running in 2 days. And I don't know if for the people who have done it, if that's been an experience where people that take it easy after do better. It takes a few days for all these growth factors to take effect, right? So just like you want to heal from your surgery, you could probably walk after your surgery a little bit more, but just take it easy for a few days. Now, what about tendon work? Like, just say it was an Achilles or something, or a posterior tib tendon. I'll put them in a boot. Like, if they had, what would I do after an acute injury? That was bad. I want this to heal maximally, and that's how I kind of convince the patient to go along with it, because nobody wants to wear a boot, right? But if they're going to drop money, this has been a long-term problem that's 6 months, a year, like 1 week is going to be good. Time it for when you're not going on Thanksgiving break and stuff like that, and you're running around an airport. So I kind of make that pretty strict. Now, in terms of crutches, I don't always put my patients on crutches if they kind of tell me they're going to work from home and really take it easy. Like, nobody likes using crutches, right? You probably had them yourself. Nobody uses them. So if they're going to be reasonable. Now, just say I have someone like with a patellar tendon and this is like a college athlete and they got to be back in 2 months. I just tell them using crutches is going to let you rest better. Like, do everything you can to make this get better. And I let them choose. Because even if you give them to them, they'll probably throw them away. Post-op hinge braces, like keeping a patellar tendon in extension. Because, like, for patellar tendon, a lot of times it's a high-grade partial tear. You probably had some of these patients. They just can't get back to sports. So I'm doing a combination needle tenotomy with a PRP injection right on that area. And then if they have an offloader brace or something like that, or they've never used one, they're arthritis, might be a good time to get them an unloader brace. The safety, again, has been really good. Like, knock on wood, I have not had any infections, all that kind of stuff. I probably do at least 4 PRP injections a week. I've been doing that for a while now. So, I think these systems are pretty sterile and pretty safe. And you don't get a lot of reactions. Some of the hyaluronic acids can have some bad reactions, pseudosepsis, things like that, steroids, that kind of makes your sugars go up and things like that. I think it's a good alternative for sure. So I'll wrap up by just telling you a little bit about what we're doing over at UCSF. We have the PRP COBE study, which is like the knee osteoarthritis biomarker exploration. I got connected with some really cool basic scientists that are doing animal kind of investigations with PRP. So they found that they take young PRP from a young mouse, inject it into the older mice, and they got smarter. So they're studying Alzheimer, and they found that these mice they could run through mazes better, and they would avoid pain stimulators better. But he's got published in Nature and Science. He's like really hot right now, and everyone's into the anti-aging thing. So it's not just Alzheimer's. It's like, is this PRP able to make cells a little bit younger? And so we're just basically doing a randomized control trial of 60 people, but we're doing the proteomics. We're trying to take blood and knee fluid from these patients after PRP to see what proteins are changing. And in his studies, we found this thing called platelet factor 4, which is just one of the platelet things. When I asked my dad, he's like, yeah, I know all about that one. But it's like, how is it working in other areas of the body? And so this is just one marker, though. So that's kind of what we're trying to see. Is there something in these, when we do it to humans, and then we have these mouse models that we're going to be able to see and maybe be able to change to see if that's really how people are getting better. And there's some really cool people at the General Hospital that they take actually plasma from all the trauma patients and they're studying it. So another part that we're doing is we're taking blood and we're really trying to characterize the platelets, because maybe some people have better platelets. So, one last thing that I'll just throw out there and then I'll open up for questions is there's actually the ability to freeze dry platelets. So in Japan, this visiting prof I just kind of ran into him. He was just visiting and I was asking him how he does it. They actually send the blood to the lab. They freeze dry it. They send you back a little vial, kind of like your steroid injection. He resuspends it and then he injects it, and it's effective. So we're kind of got another grant out there that if you could freeze dry this stuff and maybe you can take young platelets, get these things, get little vials, you wouldn't have to do all this spinning and stuff like that if it's really effective. But I think in my mind, we still need to know what is it that's working. Like just injecting platelets is still a little basic. That's the vehicle. What in those growth factors? If we ever find that out in the pathways, it's probably going to change a lot of what we do. All right. So just to wrap up on what I kind of tell my patients, and I really want to open it up and have some discussion. Unfortunately, you can't use anesthetics, so this is going to be a painful procedure, so I get people ready for that. But I also tell them, like, it's not going to be horrible either. Everyone makes it. I don't want people not sleeping for a week before their PRP injections. Ultrasound is definitely helpful to guide it, so I try to use it when I can. I get them to stop the NSAIDs at least 1 week ahead and then at least 3 days after. And then I get them to rest. So I'm pretty adamant on trying to convince them, because it never goes bad if they're resting a little longer. It goes bad when they're running around and doing stuff they're not supposed to. But I'd have to say that I'm really conservative. There's definitely doctors out there, you probably had them, their patients come back, it's like they told me to take 2 days off and I can do whatever I want. And it still works in a lot of those people. So until we get better understanding, that's kind of where I am. So I think what we've kind of, or at least where I am with PRP in 2024 is this is kind of a really cool technology. Like I've been in practice here at UCSF for 21 years, and a lot of the things I'm doing is somewhat still the same. But PRP over the last decade, I would definitely say is a really interesting treatment that we've got. And in my mind, if you think about everything we apply steroid injections to, like PRP could probably do this. If PRP does have anti-inflammatory effect and can stimulate immune response with repair, that's better than steroid injections. And you see how many kind of comments on steroids is kind of like a lot of people are kind of on steroids are bad. I still think they're useful in many indications too, but I think if there's a better technology out there, that's better. I think there's a lot of decent evidence for tendon and good evidence for arthritis and degenerative changes with the cartilage, but the systems aren't all the same, and we still got to figure out how important is the dose question. Seems like higher is better, but that's more blood and stuff like that. And then I think love to hear from the PTs and people who have had patients who have done this, like what their post-injection protocols are and recovery. But we obviously need more studies. So, all right. Cool. Pinder?
Yeah, what do you tell people after their PRP when they can expect to feel?
Yeah. 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 So yeah, this is the exact verbiage that I kind of use for my patients. Like, when are you going to get better from this thing? I usually tell them that not everybody gets better. I kind of find around 70 to 80% of my arthritis patients feel better. And then with other tendons, depending on what the scenario is, like you have a really bad tear or hamstring, like that's hanging on by a thread, the percentages, I adjust them. But I'd say the tendons, like tennis elbow, just a straight up tennis elbow that's been around for 3 to 6 months and they're not good. Similarly, it's around 70, 80%. Now, other people that are going to get better, I kind of give them that around 80% of those people will feel improvement within 2 weeks. But I've seen some delays, like between 2 to 6 weeks, that people just took a little longer to get better. And I kind of tell them, if you're not feeling it by 6 weeks, I don't think it did anything. But that's just me, and I don't think I've read anything that's like really describes better science. So that's all anecdotal.
Sorry.
Yeah, sure.
What about the degree of arthritis? You mentioned on the slide earlier arthritis.
Yeah.
But everything works well in the later.
Yeah.
Later arthritis.
Yes, surprisingly for late arthritis like grade 3 and 4, I've had a lot of patients that actually responded where they failed the steroids and the hyaluronic acid. They just didn't want to do knee replacement. Yeah. Patellofemoral I always find is hard, no matter what we're treating. That's the worst arthritis in my opinion, like just getting it right there for active people. You can't offload it and it just never goes well. But no, I've been shocked. Like I have a handful of patients that should have got knee replacements. And I would say 5 years ago, even our knee replacement surgeons were all like, this is all voodoo. I don't want to do it. Now they're all sending them down. So, yeah.
Doc, do you feel those numbers are the same for the active people? People want to go back to the tennis rates. Do you find the same success rates? And with the ultrasounds and the tendons, are you guys looking after the fill? And what's the kind of problem, what that is if it's there?
Yeah. Great question. So there's a couple questions. He was asking, like, for more active people, how well does the PRP work? And then what do you see on ultrasound after we do these things? I'll comment on a case. Like you get these young basketball players with the patellar tendinopathy. Maybe there's even up 50% or tear. And they're moving, but it's painful the whole time. They do well. I think just like healing, younger patients are gonna do a little better. They just got better healing potential. Once you get over 18, unfortunately, we're probably all there. You get in the 40s and like things are not going. These tendons aren't that great anyways now. And I think, but they're also not doing the same kind of thing. Like, I think your athlete coming in at a really high level, you just need to make them a little better. They're already doing their thing. So you make them a little better. I kind of find it makes no difference. Now, when I look at the tendons, it does fill in. It does change. You get a gap, or you got a lot of hypoechogenicity if you saw the tendon stuff, and you're just seeing less. Or you see a lot of hyperechogenic stuff with a lot of scar tissue. And after the tenotomy, you break it down and it looks better. I don't know if any of the others had that experience, or Dr. Hadamiya was here earlier, but question?
So I do PRP in my practice.
Yeah.
Also a patient.
Cool.
And, my lateral condyle.
Yeah.
I had 2 years of pain. I was miserable. PRP was painful, and I hurt.
Yeah.
But in 6 weeks, it's been 2 or 3 years. I'm 100% healed.
Yeah. Yeah.
I've had CMC joint by two toe joints.
Yep.
My joints don't have about 6 weeks or so.
Yeah.
But my tendons are 100%.
Yeah. Yeah. No, and that's the kind of stories that I've experienced as well. I think everyone who does this regularly, I think we just need to understand it. It's interesting at UCSF, we've got a lot of pain scientists, and pain's just a funny thing. Pain in my mind is kind of all over the place. It's very subjective. But your function is not. I care way more about the function and how people return to things as judging whether that works or not. But I think both improve, pain and function. It's pretty cool. Question?
What about other biologics? Bone marrow aspirate?
Yeah, so there's like 3 kind of really popular ones. The bone marrow aspirate is basically putting in the iliac crest and drawing the blood out. You've got the amniotic fluid stem cells there, and then there's you can get some from the fat as well. You almost have this little liposuction thing, and you prepare it like that. They all work. There's all got evidence in the literature that they are beneficial. Compared to PRP, some of them are somewhat similar. So they're definitely a lot more involved. You're basically doing a bone marrow aspirate in the iliac crest. So it's definitely a lot bigger scale, also a lot more expensive. So we haven't been doing it as a treatment at UCSF until we can demonstrate that it's way better than PRP, or somebody does. So.
Hold on.
Yeah.
Amniotic, not stem cell therapy, not approved right now in the US.
Right. Yeah, you have to go to.
Don't send your patients for that. It's been taken off the market.
Oh, how's it?
To be efficacious, you have to get it off label, basically off market, and the FDA is more.
Okay. So stop those patients going to Mexico. Awesome. Oh, question?
For like the higher level KL score arthritis patients that you've had, have you or are you aware of any like data supporting like improved range of motion in the joint, or is it just like a symptomatic?
Yeah, that's a great question. I haven't seen data about improving range of motion, but when I get that question from my patients, I tell them it's not going to increase your range of motion. If it's pain-related loss of range of motion, because sometimes the arthritis just hurts so much, right? They know not to bend past 90. You take their pain away, they get up to like 100, 105. That's just pain relief in my mind. You're not actually physically changing the surface of that joint, that they're just going to all of a sudden go to 130. And so I kind of make sure that's always an important one for the hip, right? People can't get in their car. They can't move and they want PRP to save them from this. But like I tell them, your pain will be less, but you're not going to move better. So you're still not going to be able to get in your car properly or cross your leg. So that usually kind of also, if range of motion is what they want, then they got to do something more advanced.
Thank you.
Yeah.
Sorry, what
Yeah.
about PRP for the SI joint?
PRP for the SI joint. There's literature that PRP helps in many spine conditions. We actually have some new PM&R docs. Some of them are here at the course, and they're actually interested in doing this. Are some of the other spine interventionalists have been more steroid. They haven't really adopted that. But I know people in the community do the PRP, and they're experiencing similar results. I just think the back is so complex. And then again, it's pain, right? This is another weird one where there's more than one joint, right? You inject one facet joint, like the disc is not good. I think maybe that's why the spine team just trying to stay away from it. All right. Well, I think we got another break, so go ahead and I guess be back around 5-7 minutes, something like that. Okay. Thanks, everyone.